I am a molecular professional. I'm a PhD geneticist, certified in clinical molecular genetics by the American Board of Medical Genetics. I direct a clinical molecular genetics laboratory at ARUP Laboratories, which is a national reference laboratory. I'm asked why I am concerned about the FDA draft guidance because I obviously advocate for patient care and high-quality clinical testing. Well, I have several concerns. The first concern is that the FDA has underestimated the impact that their draft guidance as written will have on clinical testing and therefore on patient care and patient access to these tests. The FDA's first step is for CLIA laboratories to notify them of their LDPs so they will know what is out there. That's a phrase they've used several times. In talking with the FDA, they were surprised when I mentioned the number of potential high-risk tests a reference lab such as ourselves may have, and they countered that there aren't that many out there. I was surprised that the FDA didn't have a clearer vision of the existing LDP landscape. CLIA has a listing of the laboratories. Many of our laboratories are also accredited by the College of American Pathologists. They have listing of laboratories, they have listing of all of our tests. The Genetic Test Registry, which is run by the National Institutes of Health, it's a voluntary registry, and it's only for genetic tests, but they have 24,000 tests in there, covering 5,000 conditions and 3,600 genes. Now, this has some international labs as well, but that may be a place to start, but realizing this is just the start because this is just for genetic testing, and the FDA guidance covers all types of testing. In addition, laboratories' websites have all of our test menus on there, and for the most part, they are easily indicated which are LDPs and which are FDA cleared. So I am concerned, and I would ask that the FDA learn from these existing sources before putting this additional burden on clinical laboratories. My second concern is that under the label of a manufacturer, that existing laboratory-developed tests may be discontinued. Labeling a laboratory as a manufacturing facility, as outlined by the FDA's draft guidance documents, will have unintended consequences to patients' access to these quality tests. We have 1,498 LDPs on our own test menu, with hundreds fitting the definition that the FDA has given to date of what a class 3 or class 2, a high risk or moderate risk would be. And so this will also include most of our molecular tests. If we go by their definition, there will be very few molecular tests that would be considered low risk. These tests are validated as per existing regulations with CLIA, and they are performed under good laboratory practices. Manufacturers are performed under good manufacturing practices, and there are much fewer tests under GMP than under GLP. And even though both of them deal with quality systems and have some similarities, there are some existing differences that are very significant and may prevent clinical laboratories from simply submitting their own validation data to have approved. This could impact clinical laboratories considerably by having to go back and redo validations or reformat the validations to try and fit good manufacturing processes. In an initial evaluation of the impact of this draft guidelines in our own laboratory, we estimated that the cost of submitting our LDPs to the FDA basically will cost the value of our entire LDP portfolio. So obviously that's not sustainable. and we will need to start deciding which tests to discontinue. Our analysis predicts that 95% of potential high-risk tests, now let me point out, high-risk tests could also be very high-benefit tests for the patient. So we may need to eliminate 95% of our high-risk tests and up to 62% of our moderate test risks. So this does represent a significant impact to our patient access to testing and patient care.